You know that feeling, maybe as you get a bit older, of constantly needing the loo? It's pretty common, and often it points towards what we're diving into today, benign prostatic hyperplasia, or BPH.
Exactly. And think of this session as, well, your focused revision guide for BPH. We're planning to cover basically everything you need: definition, causes, symptoms, how it's diagnosed, managed, all aimed at making it clear and hopefully memorable for you.
Sounds perfect. We've really tried to distill the key info on BPH, so let's jump right in. What exactly is BPH?
Okay, so BPH, benign prostatic hyperplasia, is essentially a non-cancerous enlargement of the prostate gland. And what's interesting, maybe a bit counterintuitive, is it's not the cells getting bigger, it's an increase in the actual number of prostate cells.
Ah, hyperplasia, more cells. Not hypertrophy, bigger cells.
Precisely. It's a really common thing in older men,
Yeah.
often just called an enlarged prostate.
Right. So what makes these cells start multiplying like that?
Well, the exact mechanism isn't fully pinned down, but a big part seems to be a failure of something called apoptosis.
Apoptosis, programmed cell death, right?
Exactly. It's the natural process where cells die off when they should. If that fails, you get this accumulation of overgrowth.
Yeah.
And interestingly, BPH doesn't happen in men who've been castrated.
Which really points towards hormones, doesn't it? We'll probably come back to that.
It highlights the hormonal link, yes.
Now, people often talk about LUTS, lower urinary tract symptoms, alongside BPH. Are they the same thing?
That's a really important distinction to make. BPH, the enlarged gland itself, is a very common cause of LUTS. Things like needing to wee more often, the urgency, a weaker
Lupus?
stream.
Are those classic symptoms?
Yes. But, and this is key, other things can cause LUTS too. Think infections, bladder issues, nerve problems. So while BPH is often the culprit in older men, it's not the only possibility.
Got it. BPH is the physical enlargement which can cause the symptoms, but LUTS isn't exclusive to BPH.
Okay, let's dig into the why then. What's the etiology? What causes BPH? So as I mentioned, the precise cause is still technically unknown. But the main theories revolve around hormonal changes that happen as men age.
Hormones again. Which ones are we talking about here?
The star player really seems to be dihydrotestosterone, or DHT.
DHT.
Testosterone gets converted into DHT in the body, and DHT is, well, it's a powerful stimulant for prostate cell growth. It's thought that shifts in hormone balance with age, particularly involving DHT, are a major driving force.
So DHT basically acts like a fertilizer for prostate cells.
Mhm.
Okay. Who's most likely to develop BPH? What are the risk factors we should know?
Age is definitely the biggest one. It's significantly more common the older you get. Family history also plays a role. If your father or brother had it, your risk is higher.
Suggests a genetic link, then.
Seems likely. And of course, the hormonal factors we just touched on are crucial.
Age, genes, hormones.
Yeah.
What about lifestyle? Does that come into it?
Yes, there's some evidence suggesting links between obesity and lack of physical activity and an increased risk. So maintaining a healthy weight and staying active seems beneficial for prostate health too.
Good to know. And I think ethnicity is also mentioned sometimes.
That's right. Studies show BPH tends to be more prevalent in black men compared to white and Asian men. The exact reasons aren't fully understood, but likely involve a mix of genetic and hormonal influences again.
Okay, so a mix of factors. Now, drilling down a bit, what's happening at the cellular level? The pathophysiology.
Right. So the core process is this increased proliferation, basically, a rapid increase in the number of both the glandular cells, the ones making prostate fluid, and the stromal cells, the structural tissue.
So both types of cells are multiplying.
Yes, and this combined growth leads to the overall enlargement of the prostate gland itself.
And how does that bigger gland cause all the urinary problems?
Well, think about the anatomy. The prostate gland wraps around the urethra, which is the tube carrying urine out from the bladder. As the prostate gets bigger, it can physically squeeze or compress the urethra.
Ah, like stepping on a hose pipe.
Exactly like that. It creates a blockage, an obstruction to urine flow. And that mechanical obstruction is what causes those typical voiding symptoms. We talked about the weak stream, difficulty starting, and so on.
Makes perfect sense. So if someone comes in with those symptoms, how do we differentiate BPH from other potential causes? What are the key differentials?
That's absolutely critical because you need to rule out more serious things. Top of the list, of course, is prostate cancer.
Right, always the big concern.
Definitely. Then you have urinary tract infections, UTIs, which can cause similar symptoms like frequency and urgency. Prostatitis, inflammation of the prostate, is another one. And we also need to consider things like bladder dysfunction or neurogenic bladder, where nerve problems affect bladder control.
So quite a few possibilities. Are there others beyond those main ones?
Oh, yes. You could also have bladder tumors or bladder stones causing irritation or obstruction, bladder trauma, though less common,
Mhm.
conditions like chronic pelvic pain syndrome, chronic prostatitis again, detrusor instability, that's overactive bladder muscle, interstitial cystitis, radiation cystitis if they've had radiation therapy nearby, and even urethral strictures, which are narrowings in the urethra itself.
Wow, okay. It's clearly not always straightforward. A thorough workup seems essential.
Absolutely.
Now, we know BPH is common, especially here in the UK as men get older. Can you give us a feel for the numbers, the epidemiology?
Sure. It's estimated that in the UK, something like 60% of men over 60 and perhaps 80% of men over 80 show some evidence of BPH.
Those are huge numbers.
They really are. And it has a big impact on quality of life, affecting maybe 40% of men in their 50s, climbing to around 90% in their 80s. It's pretty uncommon before 45. And as we mentioned, it can sometimes be more severe in Afro-American men.
And is there a link between the size of the prostate and how bad the symptoms are?
Generally, yes. There tends to be a correlation between worse LUTS and increased prostate volume, particularly in older men. Interestingly, the prostate doesn't grow at a steady rate throughout life. It tends to double in size roughly every 4.5 years between 31 and 50, and then the growth actually slows down a bit.
That's interesting, the change in growth rate. Okay, so we know who gets it and how common it is. Let's talk about the actual clinical features. How does BPH typically present?
We usually group the symptoms into two main categories to make it easier to think about: storage symptoms and voiding symptoms.
Storage and voiding. Okay, what falls under storage?
Storage symptoms are about how the bladder holds urine. So that includes increased urinary frequency, needing to go often, especially nocturia, which is getting up multiple times at night, and urgency, that sudden compelling need to urinate, like right now.
Right, the gotta go now feeling. And voiding symptoms.
Voiding symptoms relate to the process of actually passing urine. So things like a weak or slow urine stream, hesitancy, difficulty getting started, intermittency, when the stream stops and starts, and a feeling of incomplete bladder emptying afterwards.
Yeah, those can all be really disruptive. Is there a formal way to measure how bad these symptoms are?
Yes, absolutely. We use a validated questionnaire called the International Prostate Symptom Score, or IPSS. It asks 7 questions about those urinary symptoms we just discussed, plus 1 question about the overall impact on quality of life.
And that gives a score.
Exactly. The total score helps us classify the symptoms as mild, moderate, or severe, which guides management.
Okay. What about the physical exam? What are you looking for?
Well, usually we'll do an abdominal check first, feeling for a palpable bladder, which might suggest significant urine retention. But the key part is the digital rectal examination, the DRE.
The DRE, right.
Mm-hmm. This allows the clinician to feel the back surface of the prostate gland through the rectal wall. We assess its size, its consistency or texture, is it smooth or lumpy, and its overall shape or contour. Any hardness or nodules might raise suspicion for prostate cancer, which is crucial to check for.
So the DRE is vital for feeling the prostate itself and checking for anything suspicious. After the history and exam, what investigations usually follow?
We typically start with some core investigations. The DRE, as we said, is fundamental. Then a prostate-specific antigen, or PSA, blood test. Now, it's really important to remember the PSA test isn't a BPH test per se. It's primarily used to help assess the risk of prostate cancer.
And there are age-specific ranges for PSA.
Yes, that's right. Roughly, for men aged 40-49, the upper limit is often considered around 2.5 micrograms per liter. For 50-59, it's 3.5. For 60-69, it's 4.5. And for 70-79, it's about 6.5. These are general guides, though.
Okay, what else?
We'll often do uroflowmetry that measures how fast the urine flows. An ultrasound of the prostate can give a good idea of size and check for abnormalities. A simple urine dipstick test is important to check for blood or signs of infection. And sometimes, especially if chronic retention is suspected, we check kidney function with urea and electrolytes, U&Es.
And the IPSS questionnaire fits in here too.
Yes, the IPSS is used early on to quantify symptom severity and track response to treatment. We might also ask the patient to keep a urinary frequency volume chart for a few days.
Okay, that sounds like a solid initial workup. Are there times when you need more specialized tests?
Definitely. Depending on what those initial tests show, or if symptoms are severe or complex, we might need more information. This could include further urine tests like microscopy and culture, more detailed blood work, imaging of the kidneys and bladder if obstruction is suspected higher up.
Like an ultrasound of the renal tract.
Exactly. or a CT scan sometimes.
Yeah.
We might also measure the post-void residual volume, how much urine is left in the bladder after urinating, usually with a quick bladder ultrasound scan. In some cases, pressure flow studies might be needed if bladder neck obstruction is suspected. And if we're worried about a urethral structure or maybe a bladder tumor, a flexible cystoscopy might be done.
Cystoscopy, putting a camera in.
Yes, a small flexible camera is passed up the urethra to directly visualize the urethra and bladder lining.
Okay. Now, importantly for primary care, when should NICE guidelines say we refer someone with suspected BPH to a specialist?
Right. NICE has clear referral criteria. Immediate admission to hospital is needed for acute urinary retention, suddenly being unable to pass urine at all, or if they develop an acute kidney injury potentially related to obstruction.
Urgent situation.
Very urgent. Then, referral for an appointment within 2 weeks is recommended for several things. Visible hematuria blood you can see in the urine, suspicion of prostate cancer based on the DRE or PSA level, painful urination, dysuria, especially if urine culture is negative, chronic urinary retention, particularly if there's overflow incontinence or bedwetting at night.
Okay. What else for a 2-week referral?
Also, recurrent urinary tract infections, microscopic hematuria blood only seen under a microscope. And finally, if treatments tried in primary care haven't worked sufficiently and the man's quality of life is still poor, based on that IPSS score.
Those are really important triggers. Okay, let's shift to management. Once BPH is diagnosed, what are the treatment options?
The approach really depends on symptom severity and how much it's impacting the patient's life. It ranges from just keeping an eye on things to lifestyle changes, medications, and finally, minimally invasive procedures or surgery.
So what about for mild symptoms, if it's not bothering them too much?
For mild symptoms, the approach is often watchful waiting. This basically means monitoring the symptoms over time with regular checkups, but without starting active drug treatment.
And lifestyle changes.
Yes, simple things can help, like managing fluid intake, maybe drinking less in the evening to reduce nocturia, avoiding caffeine and alcohol, which can irritate the bladder. Bladder training exercises can sometimes help improve control too.
Okay. And if watchful waiting isn't enough, or symptoms are more moderate to severe, what about medications?
There are 2 main classes of drugs used. First, alpha blockers, like tamsulosin is a common one. They work by relaxing the smooth muscle in the prostate gland and at the bladder neck. This widens the opening and improves urine flow fairly quickly.
Quick relief then. Any downsides?
They can sometimes cause dizziness or low blood pressure, especially when standing up, so we need to be a bit cautious there. But they can be effective long-term for symptom control.
Okay, alpha blockers relax the muscle. What's the other main type?
The other main class is 5-alpha reductase inhibitors, or 5-ARIs. Finasteride is a common example. These work differently. We actually block the conversion of testosterone to that DHT we talked about earlier.
The growth promoter.
Exactly. So by reducing DHT levels, these drugs can actually shrink the prostate gland over time. The downside is they take longer to work, maybe several months, and they can sometimes affect sexual function, like reducing libido or causing erectile dysfunction.
So a trade-off there. Faster relief versus potential shrinkage, but slower onset and possible sexual side effects.
That's a good way to put it. Sometimes for men with larger prostates and significant symptoms, we might use combination therapy, an alpha blocker, and a 5-ARI together.
Right. Any other medication types?
Well, if someone has significant storage symptoms, like urgency and frequency, sometimes called overactive bladder symptoms, alongside their voiding symptoms, we might add an antimuscarinic drug, like toltrodine. These help calm the bladder muscle. Oh, and about dietary supplements, things like saw palmetto. The evidence for their effectiveness is generally quite mixed or weak.
Good to know. Okay, so medications are a key part. What happens if they don't work well enough or aren't suitable, or the prostate is very large? Is that when surgery comes in?
Yes, surgical options are usually reserved for those situations, or if the patient develops complications like acute retention, recurrent bleeding, recurrent infections, bladder stones, or kidney damage due to the BPH.
What's the standard surgical procedure?
The long-standing gold standard has been the transurethral resection of the prostate, or TURP. This involves passing an instrument up the urethra and essentially trimming away the excess prostate tissue from the inside to widen the channel.
TURP, I've heard of that. Are there newer or less invasive options now?
Yes, Definitely. There's been a lot of development in minimally invasive therapies. Options like the UroLift system, which uses small implants to hold the prostate tissue aside, or holmium laser enucleation of the prostate, which uses a laser to remove the obstructing tissue. These often have fewer side effects, especially regarding sexual function, and quicker recovery than Turret.
Holep and Urolift. What else?
Another relatively new option gaining traction is Resume. This uses steam or water vapor to destroy excess prostate tissue. It seems to be cost-effective and has shown low rates of sexual dysfunction.
Steam. Interesting. So lots of evolving options.
Absolutely. It's important to know, though, that even surgery might not be a permanent cure. Symptoms can sometimes return. And research is ongoing into other approaches, too, like prostate artery embolization, which blocks blood supply to shrink the prostate.
Fascinating. So looking long-term, what's the prognosis for someone with BPH?
BPH is generally considered a chronic condition, meaning it persists long-term, and its progression can vary a lot between individuals. Some men's symptoms stay mild, others gradually worsen.
But it is manageable.
Oh, definitely. With the right management strategy, whether that's monitoring, medication, or procedure, most men can get significant symptom relief and maintain a good quality of life. Regular follow-up is key to track things and adjust treatment if needed.
That's reassuring. What about potential complications if BPH gets severe or isn't managed effectively?
Well, the main complications stem from that bladder outlet obstruction. We've mentioned acute urinary retention, already suddenly being unable to pass urine. Chronic retention can also occur, leading to bladder overstretching and damage. The stagnant urine increases the risk of UTIs and bladder stones. In severe, long-standing cases, the back pressure can damage the kidneys, leading to renal insufficiency. Hematuria, or blood in the urine, can also happen.
So it's not just about inconvenient symptoms, there can be serious consequences.
Exactly. That's why timely diagnosis and management are important.
One crucial point. Does BPH lead to prostate cancer?
That's a common question and an important clarification. No, BPH itself is benign, it's not cancerous, and it's not considered a precursor to prostate cancer. The two conditions can coexist, though an older man can have both. And sometimes investigations for BPH symptoms might lead to an incidental finding of prostate cancer.
So they're separate conditions but might be found around the same time.
Precisely. And just briefly on screening, the idea of routine annual prostate cancer screening with DRE and PSA for all men, say aged 40-75, is still debated among different medical organizations. It's not universally recommended for asymptomatic men.
Right. That's a whole other complex topic. Okay, we have covered a huge amount today. Let's try and summarize the absolute key takeaways for revision.
Okay, key points. BPH, non-cancerous prostate enlargement from increased cell numbers, very common with age. Symptoms, storage, frequency, urgency, nocturia, and voiding, weak stream, hesitancy, incomplete emptying. Diagnosis, history, DRE, smooth enlargement typical. PSA mainly rules out cancer, maybe urometry ultrasound, management stepwise. Watchful waiting lifestyle meds, alpha blockers for flow, 5-ARIs to shrink, air procedure surgery, TUROLIFT, HOLEP, BRISM for severe refractory cases. Prognosis, chronic but usually manageable with treatment. Complications, retention, UTIs, stones, kidney damage if severe untreated. BPH cancer.
Excellent summary. And for remembering those key symptoms, how about thinking? Frequent urgency nocturia, weak stream, and incomplete emptying. Kind of like FUN with BPH, although as we know, it's definitely not fun for the person experiencing it.
Yes, maybe FUNWI isn't the best description of the experience, but it could help lodge those key symptoms in your memory. Frequent, urgency, nocturia, weak, incomplete.
Okay, time for a quick MSRA-style question to test things. A 70-year-old man presents with increasing difficulty passing urine, nocturia 3 times a night, and feels he doesn't empty his bladder fully. His DRE finds a moderately enlarged, smooth, non-tender prostate. His PSA comes back at 5.0 micrograms liter. What's the most likely diagnosis explaining his symptoms?
Okay, so classic LUTS, smooth enlarged prostate on DRE, age 70. The PSA is 5.0, which is just slightly above that age-adjusted cutoff of around 4.5 for his age group. However, given the smooth prostate and the typical symptoms, the most likely primary diagnosis here is still benign prostatic hyperplasia.
Exactly. The slightly raised PSA warrants consideration, maybe further investigation or monitoring, depending on guidelines. But the overall picture strongly points to BPH as the main driver of his symptoms. It's about weighing all the evidence.
Precisely. The clinical picture often points the way.
Right. So a final thought for you to ponder. As people are living longer, How might the ongoing advancements in these less invasive BPH treatments really change the landscape for men's quality of life in the decades to come?
That's a great question. Something definitely worth thinking about, the impact of these newer therapies long term.
Indeed. And on that note, if you want to revise BPH further or tackle more MSRA questions, do check out PathophysiologySimplified.com and our free resources at freemsra.com. Thank you so much for joining us for this deep dive into benign prostatic hyperplasia.